Just to give a gauge on anyone, has anyone heard of Regenexx before we get started? Okay, good. I want to just make sure, I want to give a little background before we jump in. So Regenexx is a research institute and network of physicians and clinics that was developed by physicians. And the goal of these physicians was to create a new specialty in orthopedics called interventional orthopedics. And much like interventional cardiology, the goal of this new specialty was to, or is to, treat these injuries with minimally invasive techniques using products and healing factors derived from our patient's own body. So interventional orthopedics is a new specialty developed by Regenexx, and regenerative medicine are the techniques that are employed within that specialty. And regenerative medicine is defined pretty simply as using growth factors, stem cells and platelets derived from our patient's own bodies to treat and heal common orthopedic injuries. Okay, and so that's a good, I think, foundation to base what I'm going to be speaking off of on here for the next 30 minutes or so. And if there are any questions, just we can keep it pretty open. So if you have any questions while I'm speaking, do not hesitate to ask. The biggest thing, too, that I like to hammer home is that this is all about education. So a lot of people don't know or didn't know that technology or medical treatments like this exist or existed. And so a big goal of ours is to be out in communities and doing what I'm doing today, and that is to just educate. We just want people to know that there are alternatives available to traditional care, and we'll talk about traditional care and what that route of care is. And that's it. We just want people to be aware, and then we want people to put the challenge back on themselves to go out and educate themselves and research and learn more about what we're doing, so that if one day this is something you explore, that you can make a confident decision for yourself. And that's really all why I'm here today. We're going to talk about these procedures, we're going to talk about the science behind them, and we're going to talk about the conditions that we could potentially treat. So I'm sure a lot of people in this room know, and maybe didn't know, I actually did not know this 5 years ago, that orthopedic issues are the #1 reason most people over the age of 35 go see a physician. And that is one of the variables and factors that contribute to this enormous spend trajectory that we're currently in and on, which is around $850 billion a year we're spending on orthopedic and musculoskeletal care. And that's almost 5% of our GDP. So it's this huge number that's associated with this huge problem. And there are these technologies out there that are being used effectively on a physical level, but not effectively on an economic level. And that's sort of where we came into play with trying to make these procedures available to as many people as possible, and I'll talk about that in a little bit. So when someone goes to a physician after they're complaining of a symptom, we're looking at these common treatment options and these traditional routes of care. And everyone, I'm sure, is familiar with this. If you're complaining of pain or you have an injury or you've got some sort of degenerative condition like arthritis, and you go see a primary care physician and they refer you to an ortho or a physiatrist or a pain management doc, this is pretty standard in those routes of care and an attempt, quite frankly, to treat conservatively. So the initial option is, hey, let's try to reduce some of that inflammation with a non-steroidal anti-inflammatory drug. That may or may not work long term. Let's try some steroid or some cortical-based medicines to see if we can reduce inflammation that way. We all know, I'm sure, how many people in here have had a steroid or cortisone injection into a joint space? A couple. So we know that isn't a long-term fix, but it's more of a quick fix. But could be almost damaging too in the long run, in that the physician will only allow you to have so many injections like that a year. Because they're pretty toxic to healthy tissue surrounding the damaged tissue. So, and then the last resort is steroids, or I'm sorry, opiates. We just talked about steroids. Opiates, we know the risks involved with opiates, right? And these are all that first line of defense. So you've got your Advil, Aleve, your ibuprofens, anything acting as a non-steroidal anti-inflammatory, then you've got a steroid option, and then you've got opiates. And opiates are really, there's no research to support that anyone should be on opiates over 30 days if they don't have cancer. So, and we know now that there's a huge problem in the US with abuse. The next sort of option on that route of care is non-surgical, and these are things that we actually employ often. but sometimes these things also keep those people in that cycle of care to where they're not really seeing results or complete and total healing. But you've got non-surgical options like physical therapy, chiropractic care, massage therapy, acupuncture, all good things, but not necessarily a long-term fix to the problem. And then finally, surgery. This is usually where people end up when those first two things do not work out. We're not anti-surgery. We're not going to knock surgery at all, but we do know that the negatives to surgery are these bullet points right here. You have mixed results. There's persistent pain. Sometimes you have to go in and make revisions. And then there's really no return. And I'm speaking more so to the fact of once someone has, like, let's say, a total joint replacement, and then they want to explore one of our procedures, they really can't because their biology's been removed, it's been replaced with artificial hardware, and that won't respond to our procedures. But I'll talk about that in just a little bit. So the main question that our physicians and our patients really are asking themselves is, are there other options? And the answer is yes, there are other options. And Regenexx, this network of physicians and clinics that have dedicated their medical careers now to furthering the research, treating patients, and enhancing these procedures within the Regenexx network, have really dedicated their lives to, are providing these options to patients that were, previously stuck in those cycles of care. And so the goal now is to provide these treatments on a level to where they could be potentially an alternative to surgery. And we're doing just that. So to understand the concepts in which these procedures are based on, I want to take you through just a quick little science class of what the body's capable of doing on its own, by itself, without any help. This is what happens when you incur an acute injury. This is what happens when you have a little trauma. This is what happens when you cut yourself and bleed. These are the stages that you progress through after you have an injury. Your body's response: inflammation, proliferation, maturation, or remodeling. And that can take up to a year. Inflammation is probably the most common one that we all know and recognize, right? It's associated with pain, soreness, red, swelling, tenderness. And this is the classic first sign of an injury. And this is your body's what your body's doing here is its initial response is to start the healing process. And what it's doing, or attempting to do, is recruiting any cells responsible for initiating the healing process. One of the first cells on the scene are your platelets. One of the classic signs is increased blood flow after inflammation. Well, in your blood, you have your platelets. In the platelets, there are proteins that contain growth factors that stimulate local healing cells. Your body then starts to turn on and do its job, and starts a little mobile factory of sucking in damaged tissue and spitting out healthy tissue, right? And that's sort of what's happening when these cells go to this area of injury. They're stimulating the local healing cells. And then you progress on to the next few stages where we all know this as, hey, I feel a little bit better, I'm getting some flexibility back, I'm getting some range of motion back, pain is decreasing, things are starting to look up. And this is just your body progressing through these natural stages, okay, until you've reached the point where you no longer notice that you have the injury, the pain is completely gone, and you have your normal strength and flexibility back. And that can take up to a year. And I always I use an analogy of two good ones, I think. The classic sprained ankle, right? That's the one that I can at least relate to myself, is that you sprain your ankle, you don't really seek medical attention for it, but you do realize that as time goes on, it gets better and better and better. Maybe around that 3 to 6 month mark, you feel pretty good, and so you start to kind of give yourself a little more activity, but you're really susceptible to re-injury and maybe spraining it again. But then you notice 6 months later, you're back to normal and your ankle completely healed itself with no medical attention. And that is exactly what's going on in those little microenvironments after an injury like that. And then the other one, too, that's really intuitive of how these procedures work is when you break your bone, okay, the doctor just sets it and casts it, right? And then 6 to 8 weeks later, it heals itself. Well, your bone marrow is very rich in these particular type of healing cells that we're going to talk about in a second. And then it's exposed to your blood, which is rich in platelets that stimulate those cells. And that's what helps the bone grow back. So those are the concepts in which these procedures are derived on. And that's exactly what our physicians have figured out to do in a lab outside of the body, and then reintroduce these concentrated cells back to the body. And this didn't happen overnight. We've been doing this, these guys have been working on this type of procedures and research since the late 90s. all the way to when they treated their first patient in 2005 in Colorado. So buzzwords. I don't know, everybody's heard orthopedic stem cell transplants, stem cells. There's a couple things we want to get out of the way right away. These are your own stem cells, no one else's. These are not embryonic stem cells. We're not compromising life. We're not being controversial in any way, shape, or form. These are stem cells derived from your own bone marrow. Okay, and the physician draws a little bone marrow from right above your butt almost. Everybody's got these dimples back here, and they go into the sacral, the thickest portion of the iliac crest, and they draw some bone marrow from a few different spots. And in that bone marrow is very rich with these particular cells. Way back in 1988, they figured out that these cells can differentiate into these tissues. And they're specifically orthopedic tissues. So I want to do a quick stem cell 101 real quick. A stem cell are unidentified cells in our body that are on reserve that have the ability to turn into cells that are responsible for creating healthy tissues. So when a cell is dying, it excretes a chemical to let surrounding cells know, hey, I'm dying, I need to be replaced. A stem cell will create a copy of itself called a progenitor, and then a stem cell to be held on reserve for the future. The progenitor can move forward and turn into any one of these things, or turn into the cells that are responsible for turning into these healthy tissues. So that's a real basic 30,000-foot view of the science behind what our physicians and teams are capable of doing. And those are the cells we're using. Now we've been faced with many challenges in the past 12 to 13 years, and we've done, about 50% of the world's research pertaining to this industry and field we've conducted. We've published over 100 papers in the National Library of Medicine. We've treated over 52,000 patients. And so we have a ton of data, a wealth of data. And we know for that reason that we needed a certain number of cells to see any sort of optimal results in our patients. Any sort of healing to take place, we needed at least 400 million cells. And this was a trial and error. This was a science experiment, essentially. And the way we were doing that prior to this, and that's why you'll see down there previous methods to get cell count were not FDA compliant. And we'll talk about that in a minute as well. So what we were doing, because we knew that we needed a certain amount of cells, is we were drawing some bone marrow, we were isolating those cells in the bone marrow, we were culturing those cells with some growth factors derived from our patient's own blood, and we would culture them for 30 days, sometimes more. And those cells would just start expanding upon themselves and grow and grow and grow and grow until you had billions of them. Well, that is where we then were determined to not be compliant with the FDA, and that was 5-6 years ago. And so we moved that operation offshore to another location, and in the US, we were faced with the challenge of how do we obtain these cell counts that we know we need. And that is those are the processes now that we have patented that no one else can do. We're able to obtain these cell counts from the human body and do all these procedures all in one day and still maintain and get the outcomes that our physicians desire with our patients. So very, very cool on our part that we now have these patented processes that was our response to the FDA. And the FDA, in fact, ruled in favor of us being compliant then. So pretty amazing that there's a company in the United States that's able to produce this technology and be within the guidelines of this monstrous organization that has a pretty loose whip. So we are proud to say that everything we do is compliant with the FDA. And that's a big thing. Our patients ask us that all the time. So what do we treat? And I was having this conversation earlier. Every joint space in the body is made up of those characteristics that we just saw: muscle, tendon, ligament, bone, cartilage. And so we treat every joint space in the body because of that. So if you don't see anything that you may be suffering from, everything's on. It's on this list, but it's certainly not limited to. But we'll just kind of run through this real quick. This can be a more time-consuming portion of the presentation. But the shoulder, anything from rotator cuff to recurrent shoulder dislocations. The elbow, tennis elbow, golfer's elbow, or epicondylitis, that's a very common condition. Nerve entrapment, arthritis in any joint space, depending on how severe it is. The hand and wrist, carpal tunnel, trigger finger, again, arthritis, instability. Anything in the back and neck, from radiculopathy to lumbar facet, rib instability. The hip, bursitis, arthritis, tendinopathy, labral, labrum tears. down to the knee. So the knee is probably the most common joint space we treat. It's one of our biggest weight-bearing extremities. And so with that, just as the longer we live or the more active we are, you're going to get injured or feel some sort of degeneration going on in this joint more often than you would in any other joint space probably. But pretty much everything in the hip, depending on severity. Okay, and I'll talk about candidacy here when we walk through the evaluation portion of what it looks like to come see one of our docs. But the ankle, again, a lot of conditions and injuries in the ankle as well. And conditions treated are listed on that pamphlet I handed out to you, or the one Conrad handed out. Data, research, right? Everyone is extremely curious as to where is this, how is it housed, how do you collect it? Every single patient that we've ever treated, per their approval, is into a registry or database where we track them ongoing to track their results. Now it's registry data, so it's all the patient's opinion, but everything we do is housed in a live outcome web-based tracker where it's completely transparent and available to anyone that can go to our website. So this is an example of what some of that data looks like. This is from 2 years ago, but this was a sample size of around a couple thousand patients, and it just basically shows the mean improvement of all patients throughout a certain span of time. You can find this at Regenexx.com as well as all of our clinical research. We've just published 2 randomized controlled trials pertaining to knee osteoarthritis and ACL tears, both of them in which were positive results. So randomized controlled trials are considered the gold standard in research, and we're continuing to do these studies and tests, but have published the ones that we've recently completed, and they take years to do and complete. But they're favorable, so we're excited about that as well. These next 4 items are really kind of going to be the breakdown of what it would be like if someone came to see one of our physicians, all the way from being evaluated to determining candidacy for one of the procedures to actually having the procedure. So we'll kind of talk through these points here. So the evaluation with any Regenexx physician, whether it's in Des Moines or whether it's in California, is very similar. Everything we do is standardized across the United States. So it's always a 1-hour exam, maybe longer, and that's with the doctor. That's not with his staff, that's not with someone else, that's with the doctor. And he is going to basically answer any of your questions, talk about your specific injury or condition, and then talk to you about your treatment options. And it's a lengthy, in-depth process. He'll sometimes, or most of the time, use ultrasound to help diagnose, which everyone's familiar with the ultrasound machine. It's a way for them to look at soft tissue in real time, and he can diagnose using that. And then basically this whole approach that these guys or these physicians have created then is implemented into your exam as well, and they call it the SANS approach. And this is the way they're examining your specific injury or your condition. And we'll walk through that real quick too. So they're going to look at the stability of the joint space. They're going to look at the articulation of the joint space, the neuromuscular aspects of the joint. How's the neurological aspect of how these muscles are supported? The symmetry. Why is one side one way and why is the other side the other way? And these are aspects that these physicians put into this exam to give them a way to really determine if these procedures are even an option for the patient that's there that day. And our doctors always say, if there's a person coming in for the knee, they're going to evaluate the joint space below, the joint space above, and your back to really kind of see what's going on. And they love using the analogy of if you have a bad axle on a car that's causing your tires to go bald faster than they normally should, you wouldn't just keep changing the tires. You have to go find where the actual problem is originating and treat that joint space as a whole as opposed to just treating the symptom. So that's something that our physicians take pride in, and that is evaluating and treating the joint space as a whole and everything associated with that joint space. So after that initial evaluation, the physician's going to devise a treatment plan, and it may or may not include you being a candidate for one of these procedures. Now, we probably treat about 85% of the people that come in the door. There are some contributing factors that would make someone not a candidate. Severity is one of the bigger ones. So if if the injury or condition is too severe or too far gone, we would advise against treatment. We wouldn't recommend that you move forward with something like this. Or comorbidities. So if there's some other medical issue or health-related condition that a patient has, that there are medications they can't come off of, there are certain medications they're on, or any active malignancies going on in the body, our physicians would want those things to be under control prior to this being the primary treatment plan. So the two procedures that our physicians would recommend if a patient was a good candidate, one is a blood-based procedure. And that is where we're just going after the platelets in the person's blood to initiate some healing on some minor injuries or conditions, moderate to less severe, is what the platelet procedure would be for. Okay, and that's a one-day procedure. The patient comes in for a blood draw in the morning, simple blood draw from the arm, and that blood then goes to our lab, which is in our clinic. And what they're doing basically is ridding the blood of any red or white blood cells and in an attempt to isolate your platelets. And so the physician gets back a pure amber platelet-based product. And the reason why they want that is because they're trying to get those growth factors to the area of injury or condition. And we know from the first few slides that these growth factors help stimulate and initiate the healing process. And so that's the reason behind why they're wanting the platelets in these samples, is because they're very vital to the healing process. The second procedure that our physicians would recommend is designed and reserved for more severe injuries, moderate to more severe conditions, big tears, moderate to severe arthritis, injuries that could potentially be called for a total joint replacement. There are instances where our physicians could treat those individuals and help them avoid those major surgeries. And if that is the case, it's a combination of 3 procedures performed throughout the span of 1 week. And these 3 procedures are literally emulating those 3 stages of healing that I talked about at the very beginning, all the way from creating inflammation to trying to get you back to that proliferation or maturation point where you're all better. So the first portion of that procedure is called prolotherapy. Has anyone heard of prolotherapy? Conrad has. He's had it. So prolotherapy is basically, it's a dextrose solution. It's sugar water or an irritant. And this has been going on since, there's evidence dating back to, early times, 50, 60 years ago, of people injecting irritants into the body to initiate the healing response that the body's capable of doing itself. So prolotherapy is designed to do just that. Our physicians are going to tighten any lax ligaments, and then they're going to also create an inflammatory response in the joint space or in the injured area. And they're doing that because they want the body to turn on anything that it can. Now, that injury is that way for a reason, because there's not enough of it there. There's not enough healing factors there to progress to completion, right? But if you initiate it or kind of jumpstart it, you're tilling the soil, if you will, to be preparing that area for the next 2 procedures. So 48 hours after that procedure, our patients come in for a bone marrow aspiration, and that is the portion of the procedure where we're deriving bone marrow from your hip. And it's not a bone marrow biopsy. It's a fairly comfortable procedure. Maybe Conrad can speak to that as well afterwards, but it's about a 40-minute procedure, 45 minutes from start to finish, and they're drawing enough bone marrow from both sides of your hip on the back side to ensure that they then end up with an end product that's enough to treat and heal or treat your specific injury or condition. So you come in the morning for a bone marrow aspiration. That bone marrow is sent to the lab, and it takes about 2.5 hours to process that marrow. And what they're doing is isolating those mesenchymal cells that are present in your bone marrow. And then we're counting them, and we're checking the viability, meaning we're checking to see how many of them are still alive upon re-injection. So pretty lengthy process there. And then the patient comes back, and their product is prepared for injection, and they are prepared for the procedure, and the physician moves forward with doing that portion of the procedure, which is implanting the cells that are needed to start the differentiation process to turn into those cells that are responsible for turning into healthy tissue and ultimately, hopefully, healing the condition or injury. So far we've created inflammation. We've initiated the healing factors into the area of pathology. So the third day, or the 48 hours later, or the next Tuesday, we're going to stimulate those cells with your own platelets. So then you come back in the morning for a blood draw, and back later that afternoon for the re-injection. So the third part of the stem cell procedure is the platelet procedure. And what we're doing there is giving those cells that are responsible for turning into healthy tissue the stimulant they need to differentiate. So they really won't work all that well without being stimulated. So our physicians try to do this in a layman's terms is that they want people to think of their stem cells as construction workers and platelets as the coffee for the construction workers. So easy way to think about that and how that whole relationship between the two work. So we're creating inflammation, we're introducing healing cells, and we're stimulating those healing cells. Okay? And then 2 weeks later, our physician's going to give you a call. He's going to have some restrictions for you to follow. He's going to maybe put you in a brace depending on what he's treated. You're going to have communication between your provider and yourself to help track your progress. At 6 weeks, you're going to come into the office for a follow-up exam. 3 months, you'll come into the office for a follow-up exam. 6 months, you'll come back, and that's really where the physician will determine success or failure of these procedures. But again, if you look back at the first few slides that we talked about, the healing process can sometimes take up to a year. So a lot of our patients report improvement on a progressive scale. So someone will say, hey, I'm doing pretty good at 3 weeks, I'm doing even better at 6 weeks, I'm doing even better at 12 weeks, and so on and so forth. Now, people are always susceptible to re-injury, you're always susceptible to degeneration, so that's just always one thing we like our patients to keep into mind. And patients will do some physical therapy, sometimes twice a week for 6 weeks. So the protocols after the procedure are similar to those after an orthopedic surgery, but much less. Okay, any questions here? So just to kind of recap, everything we do is autologous, meaning it's from you, and it goes back to you. So there's no chance of rejection, no chance of something turning into something it's not supposed to. These are your cells. Everything we do is safe for the stem cells, all the way down to the anesthetic we use. And what that is doing is ensuring that all those cells remain at least at a 92% viability, meaning that that's how many of the cells are still alive when we re-inject them, almost all of them. The stem cell count location, that portion of the hip that I talked about, that's where we know just via our own research through the past decade, there's these reservoirs of bone marrow that house a very high count of the cells we're going after. And then the multiple draw extraction technique, and then everything we do is done under guidance. Very important to note that nothing we do is done blind by any of our physicians. So they're utilizing ultrasound to inject you, or they're utilizing fluoroscopy. So all of our procedure rooms are equipped with fluoro, the big C-arm that takes a quick X-ray, allows them to position and reposition needles precisely where they're treating. And then ultrasound allows them to see a real-time image. So everything that they do in the lab all the way to the procedure is designed to achieve optimal results for our patients. So that is important to realize. It's not, hey, let's draw some blood, put it in a centrifuge, 10 minutes later we'll inject it into your elbow and then we'll cross our fingers. These processes and protocols have been developed for over a decade, and with that in mind, from processing to procedure, it is to achieve optimal results for our patients. Much like you would take 10 milligrams of X medication to treat this specific condition. What we do, our physicians look at it as prescription for pathology, from lab to procedure. So if they need 5 times the amount of platelets that you can produce naturally, they'll order 5x platelet. Or if they need 10x platelet, they'll order 10x platelet. Certain pathologies call for certain concentrations. And so the way to customize in the lab really sets our patients up for success.
Does age determine success?
Sometimes it can. Now, you know, the older we get, the less we heal properly. But our oldest patient to date is 95, and she's doing fine, she says. She's in less pain, and she's more mobile. But, you know, that all... Success is very subjective, so someone's 10% could be someone else's 50%, but it really all just depends on the expectation of the patient as well. So, but no, I mean, it can and it can't. It just depends on the physician and what his treatment plan for you. Yes?
What are the potential risk factors and side effects?
Yeah, so side effects are mild to moderate pain and swelling at the site of injection. Risk factors are no more than that of a blood draw because these are all needle-based. Everything we do is minimally invasive, but every time you open the body up, you risk the chance of infection. So there's always a chance of infection. You could have an adverse reaction to some of the anesthesia medication we're using, adverse reaction to an oral sedative that we use if the patient requests. Just those very minimal risks. And the risk that it might not work.
Do you give antibiotics prophylactically?
Nope. Nope. So there's cleaning solution, everything. It's a sterile environment, cleaning solution, and then the sterile environment is the major player there. Any other questions before I?
Oh, I have.
Sure.
You mentioned something about you had to go offshore.
We did. We still have a clinic in the Cayman Islands. Yep.
Okay. Is it because the government is not supporting this? Or?
Well, so what was happening? So we're not offshore. We have 43 clinics in the U.S.
Right.
When I was talking about the FDA earlier, that had to do with one specific procedure we were doing, and it's called the Regenexx procedure, and that's where we were culturing cells. And we don't. That's really designed to treat more severe injuries. Okay. So, but yes, we have a clinic in the Cayman Islands where it's not under the jurisdiction, obviously, of the FDA, and we're culturing cells or we're manipulating them. And in their minds, that's creating a drug.
Now, our daughter, when our grandchildren were born, had all the stem cells frozen here in Florida, and they could be used for the children, some close relative. But the same procedure would be for those as it would be for you, right, with your own stem cells?
Yeah, yep. So we're not banking cells like what your daughter did. So she would bank those cells for future use for those children. So, but when we're treating our patients, we're using our patients' own cells, but we're doing everything in one day. So we're taking a product out of your body, we're ridding it of everything except for those particular cells, and then we're using those cells in the same day.
That really sounds simpler than.
It is. It took us a while to figure that out.
Right.
Yeah. Yeah.
So what is the price range?
I'm going to get to that here in just one second. Yeah.
That's important.
So everything in the lab is done to verify viability. They concentrate and combine samples, and they verify final count. I've already kind of went over that. So the procedure itself, we talked about this. Everything is standardized across the United States. Everything we do is under guidance. SD plus stands for same day. SCP stands for super concentrated platelets. Those are the two procedures we talked about. So the insurance coverage and costs here, I'll talk about it. We're very open about this. So the procedures can range in cost from $2,000 to $7,000, okay? But the consultations, the follow-ups, any bracing, physical therapy, all of that stuff is covered by most insurance plans, including Medicare. So to even find out if you're a candidate is just like going to see another specialist. It's covered by your insurance. Now this black dot I have down here because what I do primarily for my job is I work with employers to get these procedures added to their health plan for two reasons. Economically, we're saving companies about 83% on every procedure when someone chooses Regenexx over the surgical alternative. So keep in mind that the national average for a knee replacement in the United States is about $55,000. An employer that has a patient or an employee that is in for a knee replacement, but also a good candidate for one of our procedures, would much rather pay $7,000 than $55,000. So the impact that we're having in this unsustainable industry is huge. So for the patient that doesn't have coverage, I understand that it's a large out-of-pocket expense, but it is pretty close to the national average of what people would pay for out of pocket if they went the surgical route. Most 80-20 plans are like that. Yes, ma'am?
How many employers here in the state of Iowa?
Right now we have 15. I can name some of the major ones: Hy-Vee, Polk County, Musco Lighting, ITA Group. See, I always start to forget when I do this, but I have them all. I track them. So Meredith Corporation, so that's a huge one. Casey's, General Store. A number of them, a lot. Some of the biggest employers in the state. Just between Hy-Vee and Polk County, those are two big ones. Permar Security Systems. I'll start remembering them as I start changing topics, but a lot of employers in Iowa, and then we have about 15 more all over the U.S. So what prompted Regenexx to partner with my company was the fact that we were getting these procedures covered by large employers. And so that is when they decided to move their corporate headquarters to Des Moines and let us focus on rolling this out on a nationwide basis. And that's what I'm doing, and my CEO and my colleagues in my positions are doing, is attempting, well, we're doing it successfully actually now, to make these procedures as accessible as possible to everyone. So there's no reason why they shouldn't be. If you look at research for or associated with orthopedic surgery, we now know that about 60% of them have been proven to be ineffective in clinical trials. Meniscus surgery. Meniscal surgery, the most common procedure performed in the United States, over 700,000 of them are performed a year, is no better than sham surgery in any randomized controlled trial. And I can send you the studies to prove that statement. And it's becoming like that more and more. And these procedures that they're trying to hold up to the standard of research, a randomized controlled trial, a lot of these procedures are failing in them. We've published 2 positive ones. We have a registry database of 50,000 patients in it, tracking outcomes. So we're doing all the right things, right, to get this more accepted and widely accepted. It's a prevalence issue right now. When you look at, there's around 40,000 orthopedic surgeons in the United States performing around 7 million procedures every year. So prevalent that it has to be accepted, no matter how successful they are. We have 43 clinics in the U.S. and about 70 physicians. So we're paling in comparison when it comes to the number of procedures performed versus the approved procedures. So, yes, sir?
Do we need a referral from a GP doctor?
You do not, nope. So you can call and just make an appointment. You don't need a referral at all. Our doctors can diagnose and devise treatment plan without referral.
What type of doctors do you have?
Yep, that's a great question. So our doctors in Des Moines are both MDs. They are specialists in physical medicine and rehabilitation, sports medicine, and interventional spine. So both physiatrists, if you know that physician term, they're physical medicine and rehabilitation. So these are doctors that are specialized in injection-based therapies, utilizing ultrasound to diagnose and inject, diagnosing orthopedic and musculoskeletal conditions. Same kind of docs that would be your doc that are, a physiatrist is like a musculoskeletal gatekeeper. Any ortho group typically has a physiatrist on staff that would make the determination whether or not that patient needed to move on to surgery. Is that pretty accurate, Doc? Yeah, because both of my docs were actually in that position. They were doing steroid injections, cortisone injections, but now they would say a lot of those injections can be replaced by your own platelets, and that we don't need to be introducing these toxic chemicals into the body. Yes?
Is this the one-time procedure, or do you have to do it?
Great question. So our physicians say that, yes, we want to treat you once, but sometimes there are instances where you would need a second treatment. But you wouldn't make that determination until about a year's time.
Is this privately held company?
Yes, currently. Mm-hmm. Hopefully not one day. Yes?
What is your success rate and or your infection rate?
Infection rate, I know of no known infections in our network. So, but I'll verify. And those are the clinics that I deal with personally. In the past 2 years, we have not had one infection as a result of our needle-based injections. Success rate is going to vary based on what's being treated and the patient population that's being treated. So, but our doctors say about 88% of our patients do not go on to have surgery, and we have data out to 7 years to support that. But that'll change every time you look at the different joint space and the patient
What are your
sample.
medication restrictions, you said?
Yeah, glad you brought that up. So AC inhibitors, we ask that people do a replacement or stop them. Any sort of statin can be replaced or stopped 2 to 4 weeks prior, 6 to 12 weeks post. And then, of course, non-steroidal anti-inflammatory drugs. So if you're on an anti-inflammatory medication, we need you to come off of that 2 to 4 weeks prior and 6 to 12 weeks after, because in this case, we want inflammation. So we don't want anything subsiding inflammation, because we want inflammation to occur for this whole process.
So do you just use Tylenol then?
Yep, you can use Tylenol as needed, yep. And then our docs will write a short 3 to 5 day opiate script if they need to. People will either take everything or they won't take anything. That's usually generally what they see. So, yes, sir.
What's the basis for discontinuing statin?
That's a good question. I don't know. And I can find out why. And it has to have something to do with inhibiting the success of the procedure, I would imagine. But I can find that out. That's a good question.
Are you connected with any teaching colleges or any?
That's another good question. So actually, we're affiliated with a third party called the Interventional Orthopedic Foundation, which has a fellowship program for physicians coming out of medical school for this type of specific treatment. But it's independent as well. So we're not affiliated with any major. Some of our docs in certain states have to be affiliated with hospital systems, and some of them probably do teach. But it's not standard across the network that it's mandatory. I know certain states make the physicians, all physicians have to be affiliated with some sort of health system in their market. So, in the interest that someone wants to make an appointment, it's as easy as calling the number on the brochure. You don't really have to worry about these next two slides, but our people at our admissions office or scheduling department will walk you through the next steps. If you have medical records pertaining to your injury or condition, we ask that those are gathered and brought with you or sent prior to your appointment. Those are supplemental to your initial exam and could make your first visit as beneficial as possible, and could sometimes eliminate the need for the doctor requiring further diagnostic studies. So we can help you get those records just with the release of information. Okay? Any other questions? I know that was a lot. Yes, ma'am.
So many of my friends that have had knee replacements have not been happy at all. And I think a lot of it is maybe they are overweight. Do you caution your people about not gaining weight?
Yeah, yep, that's a
working out and exercising?
yeah, so there are some lifestyle, changes and suggestions that our physicians are very aware and conscious of. There's one of our doctors in Colorado wrote a book called Nutrition 2.0, and I mean it's like the paleo diet, but in much more detail. He's explaining why it's important to eat foods that are natural and not compromised with additives and chemicals and whatever the case may be. But our one doctor, Dr. Jackson in Des Moines, always tells his patients to stand up straight and eat like a caveman. So, eat everything you can find naturally and stand up straight. That's what he says to our patients all the time. So there are certain lifestyle changes and nutritional aspects that could certainly improve improve patients' chance for success. And you look at just the way the healthier an individual is, anyhow, the better off they are in any aspect of any medical situation. So, yes, it's something that they definitely bring up. And if it's obvious that someone's overweight and they're putting a lot of undue stress on weight-bearing extremities, they got to have that talk. I mean, they got to have that talk with the patient. Some of our doctors are more blatant than others, but they do.
After they lose the weight, or?
Some do, yeah,
Do they?
for sure, yeah. There's just you're reducing so much stress.
Sure.
Yeah.
A couple of my blood tests show that I have a low platelet count. Would that hinder me from?
Our physicians would just have to work with your hematologist on that. So it'd be a peer-to-peer between our doc and your doc, and they would just have to work together to figure out the best way to move forward, if there was a way to move forward. Yes?
If you go to your own local physician and they say, okay, let's do an MRI,
Mhm.
is like the MRI is done here different from what you do down there?
Nope.
Do we request special views,
Nope.
special?
If you're being seen at our clinic for what you'd been seen for before, all that stuff will work. Yep. So if there was a diagnosis and then the MRI and then the report to go with that MRI, our doctors can use that for sure. Yeah. Or not. I mean, you don't need to have it. It will make your first visit as seamless as possible.
What would be the maximum time spent having this procedure done?
Yeah, so that's a good question. What would be the maximum time spent having this procedure done, meaning from the time you get evaluated to the time you have a procedure?
Right in the hospital.
Oh, that's even better question. So she's talking about in the hospital. Well, I'm happy to say that these are all outpatient procedures. So you're never admitted to the hospital. So you're never admitted to the risks of being admitted to the hospital either. So you come to our clinic and you can leave after the procedure every day. Yeah, these are all outpatient procedures. And you never walk out in worse shape than you walked in, right? So we're not cutting you. The reason why recovery is so long for a lot of orthopedic surgeries is because they're damaging a lot of tissue to heal a very specific pathology deep within sometimes the tissue. So we're not doing that. So our procedures are all outpatient based. One,
Brother-in-law who's a neurologist, and he's going through this right now.
oh, okay.
He's been up to Mayo Clinic, and he's come back, he's in Mercy, Iowa City. He's been in the hospital for,
Is it on call? Is he being treated for cancer or is he being treated?
I'm not sure, it's very rare, and he diagnosed it himself.
Oh, wow. Well, see, so that wouldn't, we are 100% focused on treating orthopedic conditions. So we're not treating any other diseases or conditions. But yeah, in the cases like that, I can't speak to, but I would imagine it'd be more in-depth treatment plans and protocols and, yeah.
Do you ever do anything with eyes? My daughter knows a doctor in Denver with macular degeneration, and they're doing this stem cell stuff in his eye.
I've heard of it. We do not do it. No. We're, like I said, we're all orthopedics for now. Yeah. But I know that there are a lot of advancements being made. In fact, we were talking earlier, if you have $1 million, they can heal your blindness. That's right. Yes?
Sorry, I'm having more questions.
No, I like it.
Like bunions, that's such a common occurrence, probably thanks to our shoe industry. But anyway, what type of things do they do for that? Just the injections or?
They would probably treat the surrounding ligament that the bunion is
Why it's weak?
near, yeah. So there's probably some instability as a reason to why the bunion formed. And again, I'm not a doctor, so I don't want to mislead anyone or speak out of turn, but that's generally what they would do. They would answer those questions more thoroughly as well. And I'm sure Doc could too.
We need to be surgitized for that.
Any other questions? Great. Well, thank you all very, very much. I think we're right on time, so I appreciate it. If you have any questions, you can call that or you can speak to me. I'll be here for a little bit right after this. But thank you very much. Appreciate it.